Good evening, respected teachers and my dear colleagues. Myself, Dr. Swati Trivedi. I'm presenting my seminar on first trimester ultrasound screening under the guidance of Dr. J. Prakash Shah, sir. Now, I'm presenting three cases. My first case is a Mrs. AO, 37 years old married female. It was a non-consanguineous marriage. She was second gravida, previous one normal delivery, uneventful pregnancy, spontaneous conception. She had regular menstrual cycle. There was nothing significant in past medical, surgical, personal, or family history. She was referred to a center at 15 weeks and 4 days for second opinion after a normally reported first trimester scan, but increased risk for T13 and 18 in dual marker. As a routine, we reperform the scan of all our patients who are referred to us for second opinion or for invasive testing. So, as a routine, we perform the scan of the patient as per the guidelines and got the following findings. Now, this is the dual marker report of the patient in which the beta HCG was 0.19 mom and PAP-A was zero point 0.2 mom. I got this from FMF, in which the values of mom for aneuploid pregnancies are given, like beta HCG and PAP-A for trisomy 18 is 0.2, and for trisomy 13 it's 0.3 for both. While it is doubled for double beta HCG for trisomy 21 and half for PAP-A. In our case, we got the values 0.19 mom and 0.2 mom for PAP-A. The routine, the basic, the CRL, BPD, FLAC of the patient were not corresponding with the gestational age. She being 15 plus 4, but the parameters were 13 plus 3 week. So we were suspecting early FGR. Now, this is the almost mid-sagittal section of the fetus, and this is the mid-sagittal section demonstrating micrognathia. And this is the retronasal triangle view in which we can see that the usual space which is present in between the mandibular rami is absent. There's no gap between the two rami of the mandible. Symphysis menta is absent. And this is again the mid-sagittal view in which we can see some cystic posterior fossa. We can't comment very much on the posterior fossa malformation, but we can see that the posterior fossa is cystic. Now, the rest all the systems examined were within normal limits. Our provisional diagnosis was trisomy 18 based on the ultrasound markers of micrognathia, posterior fossa malformation, and early onset FGR, and also on the values of beta HCG and PAP-A, which were obtained on double marker. We counseled the patient and attendants about the high probability of Edwards syndrome in fetus and pursued them to undergo invasive testing for the confirmation of diagnosis, but they refused. They again came back to us at 16 plus 6 weeks, almost 10 days later, for repeat scan, considering the malformation might have resolved. We again scanned the fetus. We even had the curiosity of confirmation of the posterior fossa. So the micrognathia was again there, and this time also the posterior fossa was cystic, and the angle was 29 degree. Now the brainstem vermis angle in 12 to 4, brainstem vermis angle in case of vermian hypoplasia is 35 plus minus 5.4 degree, and we got an angle of almost 30 degree. We were suspecting vermian hypoplasia because the morphology of vermis was somewhat like hypoplastic. We couldn't properly visualize the fastigium or the primary fissure. But still, for proper diagnosis, we need to comment in the 18 to 20 week scan. The patient was again counseled for confirmation of diagnosis, but they adamantly refused to undergo invasive testing. So the best option they agreed at was NIPT. The patient sample was sent for the same, and the risk came out to be high risk for Edwards syndrome. The pregnancy was terminated, and despite dire efforts, we were not able to get the autopsy specimen. Now, this is the NIPT report of the patient, which is high risk for trisomy 18, 1 in 20. Now, practical points for the diagnosis of micrognathia. Micrognathia basically refers to small chin, which is secondary to underdeveloped mandible. And retrognathia is basically the posterior displacement of the chin, in which the AP diameter will be shortened, of the mandible will be shortened. Now, it is associated with many chromosomal and non-chromosomal syndrome. Normal fetuses usually have a gap between the mandibular bodies, like here we can see. But an absent mandibular gap is found in 100% of fetus with micrognathia in the RNT, retronasal triangle view. This is also a normal fetus demonstrating the usual gap which is present in the normal chin view, RNT view. Now, practical points for diagnosis of posterior fossa abnormalities. Cerebellar abnormalities such as Dandy Walker or cerebellar hypoplasia, they are associated with an increased risk of aneuploidies, and trisomy 18 being the most common association. There's a wide communication, usually wide communication between the fourth ventricle and cisterna magna is present, in the 11 to 13 week scan that we do. And it is pathological if we see an evident posterior fossa. Otherwise, a small gap is, wide communication is normal. This closure of fourth ventricle occurs at 18 to 20 weeks gestation. Failure of closure occurs under two circumstances. Either the vermis is not developed or the fenestration of the posterior or the fenestration of the Blake's pouch is not done. Now, if the vermis is not fully developed, it will not grow inferiorly and cover the fourth ventricle from the inferior extent. And if the penetration of the posterior membranaceous area does not occur, that is the foramen of Leschka is not formed, then the Blake's pouch will grow. Sorry, ma'am. Hello? Hello?
It's okay, you continue.
Okay, ma'am. Sorry, ma'am. Okay. And the Blake's pouch will continue to extend and it will lead to the secondary elevation of the vermis and the Blake's pouch cyst if the fenestration of foramina of Leschka does not occur. Now, this is the normal anatomy of vermis in a 13-week fetus. We can see the aqueduct of Sylvius. We can see the tectum, the midbrain, pons, medulla. And then this is the fourth ventricle. This is the Blake's pouch, vermis, area membranaceae anterior and posterior. Now, my second case is a clinical scenario of a 26-year married female, non-consanguineous, again marriage, priming gravida, nothing significant in past medical, surgical, personal, family history. She was referred to our center at 13 weeks for first trimester screening. We performed the scan and got the following findings at CRL of 62.9 mm and NT 2.07 mm. Now, this is the transverse axial section of the pelvis demonstrating bladder, and there was some abdominal cyst. Here also we can see the cyst and the communication. Now, this is the communication, the fistula, the echogenic kidney, the stomach on the left side. So this is supposed to be the right side, the echogenic kidney, and again demonstrating the communication and the single umbilical artery. Umbilical artery single, and then this there was some pelvic dilatation. We can't say pelvic taxis, but there was some pelvic dilatation in the left kidney. And then again, this is and there was this something calcified intraluminal enterolithiasis. We were suspecting this might be some enterolithiasis. Then again, we got this communication. The fistula was communicating with this cyst and they were all opening into the perineum. Then this is the right echogenic kidney. Right kidney, so the images demonstrating the same thing. Left kidney with the pelvic dilatation and the right echogenic kidney. Single umbilical artery around the bladder, two vessels seen in three vessel cord. Now, based on the ultrasound findings, my differentials for the case were intravesical fistula, rectoperineal fistula, and persistent cloaca. Now, in intravesical fistula, since we were able to see the calcified intraluminal finding, enterolithiasis, which is basically due to the mixture of urine. When the urine mixes with the meconium, then it gets calcified. And we can see some calcification in the lumen. Then in that case, we can suspect intravesical fistula. And the other thing, persistent cloaca, and that is the most severe form of cloacal malformation in female. In this, the distal part of the urinary tract, vagina, and rectum all lead into a common opening, and it is associated in most of the cases with multicystic dysplastic kidney, single umbilical artery, and fluid changes. Now, we counseled the patient regarding the grave prognosis and advised for invasive testing to rule out any genetic cause, but patient refused. Thereby, the patient again came to us at our another center after more than a month, almost 18 weeks, because the first scan was done around 13 weeks. We repeated the scan to patient satisfaction to come to an even worsened fetal condition. Now, this time the single umbilical artery was seen, but this time there was no fluid. It was anhydramnios fetus, and both the kidneys were echogenic. We tried looking for the anus, but it was difficult to visualize at this stage because we need a 23-week fetus for visualization of fetus anal sphincter, which is a hypoechoic circular area with a central echogenic dot. In 90% of the cases, we can see 23-week gestation. We tried to look for genitalia. It looked like a female, but again, it is confirmed at a later gestation. We again counseled the patient for invasive testing, but patient denied. The pregnancy was terminated and we were unable to obtain the fetus for autopsy. Now, the practical points for diagnosis of cloacal malformation, also called urogenital sinus malformation or urorectal septal malformation (URSM). Now, what happens during the 5 to 7 week of gestation? There is a urorectal septum that descends, and it divides the urogen. It descends and it divides, reaches up to the cloaca, dividing the urogenital sinus and rectum posteriorly. The urogenital sinus eventually differentiates into the bladder and the genital tract. A rest of development of this process, that is the descent of urorectal septum, leads to the urorectal malformation. As we can see in this video, the urorectal septum descending and dividing the cloaca into anteriorly urogenital sinus and posteriorly into the rectum. And this eventually results in the formation of genital tract and urinary bladder. This is the final outcome, definitive urogenital tract and the anorectal canal. Now, the practical points for diagnosis are most of the cases are sporadic. Anorectal malformation is very rarely associated with single gene syndrome. Now, what signs will we get while diagnosing a urogenital sinus malformation? Non-visualization of anus, which we usually need 23 weeks of gestation for visualization. There will be cystic mass in the abdomen, which will be fluid filled, and it might have debris if it is a entrovesical fistula, because the urine will mix with the meconium. Then there can be renal anomalies, which have been reported in almost 90% of the cases. That can be cystic dysplasia, ectopic kidney, or hydronephrosis. Now, oligohydramnios, depending on the extent to which the kidneys are damaged. In complete URSM, we will get anhydramnios. Now, there's an echogenic ascites due to meconium mixed with urine. Now, the complete URSM, and there are two kinds of URSM, complete and partial. In complete, there is complete absence of the anal perineal openings and the perineum is smooth. This one is lethal. And in partial URSM, there is a single opening that leads into the perineum, which is the common opening for genitourinary and gastrointestinal tract. The prenatal diagnosis of either is difficult. Now, my third case is Mrs. DS, 28-year married female, non-consanguineous marriage, spontaneous conception. There was nothing significant in past medical, surgical, personal, or family history. She came to a center at 13 weeks for routine first trimester screening. We performed the scan and got the following findings at CRL of 78.29 mm and NT of 1.83 mm. Now, this is the grayscale and the color Doppler image simultaneously, four-chamber view demonstrating the left ventricle, left atrium, right atrium, but the right ventricle was not visualized. Same in color Doppler. The flow is like away from the probe. The flow is, there's no retrograde flow basically. And then the mitral valve was intact. And then there is two vessel and three vessel trachea view, SVC, aorta, trachea, but we could not see the pulmonary. Now, this is here we can see four-chamber view with no filling in the right ventricle. And then this is the three-vessel trachea view demonstrating only two vessels, the aorta and the SVC. Sorry. Now, this is the LVOT. Only one outflow track was visualized. This is the LVOT. And then this is the two-vessel and three-vessel trachea view. Then this is the normal NT was okay, NB was visualized. Now the cardiac axis. In a 12 to 15 week fetus, the cardiac axis is 49 plus minus 7 degree. So that means the extent is 42 till 56. In our case, we got the cardiac axis 54 degree, which is close to normal, close to abnormal. Ductus venosus waveform was normal. Now, my differentials for the case are tricuspid atresia, pulmonary atresia, intact ventricular septum, and hypoplastic right heart syndrome. Now, tricuspid atresia is atrioventricular connection. There is no connection. Then pulmonary atresia, intact ventricular septum, there is absent ventriculo-arterial connection. In tricuspid atresia, the right atrium is usually dilated and right ventricle not seen. While in pulmonary atresia, intact ventricular septum, The right atrium is dilated due to tricuspid regurgitation as the tricuspid valve is dysplastic, and the right ventricle is generally hypoplastic, but not always. And in hypoplastic right heart syndrome, it is the composite of tricuspid atresia, pulmonary atresia, and hypoplastic right ventricle. The patient was prognosticated regarding the poor outcome and counseled for invasive testing to rule out any chromosomal association. Thereafter, the patient was lost to follow up. Now, practical points for diagnosis of tricuspid atresia. The four-chamber view is diagnostic, but still we need color for the confirmation. If the four-chamber view reveals a diminutive right ventricle, a VST, and an absence of right-sided atrioventricular connection. The atretic right atrioventricular junction appears as an echogenic thickened tissue and there's no flow through the tricuspid valve. Right atrium is dilated and the interatrial communication is large because no blood is going to the right ventricle. Now, pulmonary and aortic atresia can be found on occasions. Now, owing to the abnormal four-chamber view, tricuspid atresia can even be detected in early gestation or on grayscale or combined with color Doppler. Now, tricuspid atresia has been associated with enlarged NT in early gestation. Reversal of A wave has been reported in second, third trimester, but we can get in 11 to 13 week gestation also, which is a sign of increased preload in the right atrium. Fetal karyotyping should be offered despite rare association, including 22q11.2 microdeletion. Now discussing the case, first of all, the history of first trimester screening. Nuchal translucency was first coined by Nicolaides et al. In 1992 to describe the finding of an increased translucent region behind the neck of fetuses who were diagnosed with aneuploidy at the time of CVS. This is now an integral component of most first trimester screening tests for chromosomal disorders. Effective first trimester screening is a combination of maternal age, fetal nuchal translucency thickness, fetal heart rate, along with the biochemical markers, beta HCG and PAPA. Assessment of new markers has come into picture, which increases the detection rate and reduces the false positive rate. Abnormality in any of the above markers can warrant a further search for any malformation. Now, this is the obtained from ISOC guidelines in which 23, in which we say that if we perform an anomaly scan, that is the first trimester malformation scan, along with NT assessment and prior to cell-free DNA, then we can detect trisomy 21 in 100% of fetuses and trisomy 18 and 13 also in 100% of the fetuses. And if the NT is more than 3.5, then at a false positive rate of 2.5%. Now, what is the purpose of first trimester ultrasound scan? It is to confirm viability, establish the gestational age, determine the number of fetuses. In multiple fetus, we can assess chorionicity, amnionicity. And towards the end of first trimester, we can measure NT, offer first trimester aneuploidy screening, identify women who are at increased risk of preeclampsia, FGR, preterm labor. And for most of all, it is an opportunity to detect major fetal anomalies. Assessment of fetal anatomy can be done in two ways. The first is the minimum requirement for the it is the basic survey at 11 to 14 week scan, and the other is the more advanced one, best of practice, comprehensive detailed examination. And we being fetal medicine practitioners, the best of practice guidelines are basically for advanced screening. Now, these can be obtained from the ISOC practice guidelines. I'm just throwing light on a few of them which were important for the diagnosis in our cases, like the sagittal view of the head and neck. We got the posterior fossa malformation, we got the we can get the NT, and axial view of the heart will give us the diagnosis of the four chamber view. Then bladder visible can give us the diagnosis of if there are two umbilical arteries, single umbilical artery, or if there is any associated cyst. And with the advanced, that is the best of practice guideline, if we follow, then we can diagnose all the anomalies. Like looking at the mandible, we can diagnose micrognathia, four chamber view, LVOT, three vessel trachea view. Two vessels were seen in the three vessel trachea view in the tricuspid atresia case. Then umbilical arteries watering the bladder, and the kidneys, which is not in the minimum guidelines. So kidneys, we can see the echogenicity or any if there's any other anomaly. Then amniotic fluid volume. Now, what are the always detectable anomalies? Fetal anomalies are known to affect 3 to 5% of the pregnancies. And these are the ones which are always detectable. acrania, anencephaly, exencephaly, cephalocele, and holoprosencephaly in the skull, brain, and spine. Now, situs abnormalities can be detected. Exome failures, gastroschisis, pentology of Cantor, limb body wall complex, ectopia cartus, and urinary tract we can detect megacystitis. The potentially detectable. So these are basically for the advanced screening. And we can detect open spina bifida, posterior fossa anomalies, cerebral ventriculomegaly. In the face, we can detect micrognathia, facial cleft. In the heart, we can detect major CHDs like TOF, AVSD, hypoplastic left heart syndrome, hypoplastic right heart syndrome, diaphragmatic hernia. Bilateral renal agenesis can be seen, and the limb abnormalities, transverse limb reduction, aplasia, radii, club foot, and clenched hands. Now, I'd like to conclude my seminar with the following learning points. The 11 to 14 scans should not be limited to the assessment of fetal CRL NT. Rather, it gives us an opportunity to assess the fetal anatomy well. Early identification of the fetal anatomy allows earlier genetic diagnosis and more time for parental counseling and decision making. Now, detailed first trimester scan should be followed by double marker or NIPT. Firstly, because NIPT should not be NIPT should not be approached because we can miss many information which can be obtained on double marker. And secondly, if we encounter any markers or malformation, we can directly go for invasive testing rather than going for double marker or NIPT. And both transabdominal and transvaginal approaches may be required to complete the systematic examination of fetal organs. While transvaginal examination is not mandatory, it may provide a better image resolution for the assessment of fetal anatomy. Thank you.